potentially combine inner branches, 2 here for the SMA and cilia, with 2 fenestration, 1 for each renal. There are also other options, the most common one, which is the artivion, where you can design it according to the anatomy you prefer, whether you have 2 renal arteries or 3 renal arteries, or as you like. And you have this option, the graft, which is tapered, giving you a space to enter each branch and place a bridging stent. So it's more kind of patient-tailored position and has different designs like integrated limb. You don't have to put the distal body. So it makes the procedure more predictable and the risk lower of various potential adverse outcome. Finally, there is off-the-shelf option. This is an inner branch endograft where you have a pre-cannulated branches. You see here the pre-cannulation, and that allows you to get into the branch through steps. So the learning curve is generally easier. And that covers a wide range of anatomy. So this option can allow you to enter vessel, not necessarily opposite the target, but within a range. When we look at data, so there's a lot more data on the Geotech inner branches population, some of it from our center in London, some from other centers. There's one study about the Cook design some time ago. So we are looking to bring more data, hopefully very soon. This is our center publication about this design in the Journal of Vascular Surgery. This is 1 year outcome, so it's from 2018, published about 2 to 3 years ago, and overall very good results and low reintervention and occlusion rate. We followed up our data. We have 35 cases with 5 years now since we started, and we have more obviously intervention, 2 renal branches occlusion. This is out of 35 cases, so it's kind of the average, like most endograft. But what are the benefits? The benefit can treat wider range of anatomy, more complex cases. Here you see the angulation. If you have to do fenestrated, it's going to be quite extreme angulation to get through. It's possible, but it's unnecessary if you have a different design. So this kind of option gave us more tailored way. We can also change the proximal landing zone, which is different to other branch grafts, so we can have a shorter design. We can treat aneurysm with type 1 endoleak, and that's a very useful design to treat this condition. We've all seen EVAs with a type 1 endoleak. And also, because of the design, you can do 1 vessel at a time, and you can come from below with retrograde approach. So in summary, this design will allow you to treat more challenging range of anatomies, more angulation, narrow lumen, and less unpredictability compared to frustrated repair. It's definitely easier to learn because you are doing 1 step at a time, and you have the advantage of pre-cannulation in on all of the shelf designs. Having off-the-shelf option for some of the urgent aneurysm and large aneurysm add to the offering we have. So if we have a condition where we don't have an option available right now, off-the-shelf is very useful. So those are in general, the advantage of having another endograft available for us to treat in addition to what we already have. I think that's all what I want to say about it. Obviously, very happy to take questions when the chairman wants.
Let me introduce my colleague and my co-chairman, Dr. Murad Salam. He will talk about aortic infection St. Thomas's management algorithm. Kindly proceed, please.
Thank you very much for the kind invitation and the introduction. So this talk was supposed to be tomorrow, but it is filling a gap. One of the speakers is arriving tomorrow, so it's not particularly innovation. And I think some of the audience might have seen previous talks about aortic infections that I presented in the last few years. This one is going to focus mainly on the algorithm of management. And it took us probably around, around 10 years at St. Thomas to slowly develop the service of the aortic infections. And finally, we have what we think is a reasonable management protocol that merges these two entities. One of them is the aortic graft infections, where there is a prosthetic inside that is infected. And the second one is about the mycotic aneurysms or primary aortic infection, where no prosthetic yet, the infection is in the aortic wall. Although they are two separate entities, there's a lot of overlap and similarity between the management protocol, and we'll go through that. This is the final protocol that we are using now. I don't like to call it final because I think it will be modified with time, but this is what we're trying to use, and this will be the purpose of the whole talk, to go through it, how it was built, and how we got there. There's no need to talk much about the epidemiology. Aortic graft infections are rare, but fatal and very complex and challenging to all surgeons. It is exactly the same for mycotic aneurysms, which is primary aortic infection. You are talking between the range of 2% of all aneurysms that we see, but we are still talking about a very high perioperative mortality and morbidity. Now, we keep on saying that they are rare, challenging. I think for the purpose of rare, they don't need to be a service that is very well established in every single hospital. Clearly, there isn't enough volume to make every single vascular center a big center for infection. And the reason for them being challenging is, and that applies to both graft infections and primary mycotic aneurysms. They are usually patients with multiple comorbidities, the delayed presentation, and they can come with two potentially fatal pathologies, bleeding, and infection at the same time. The nature of the microorganisms being the most important thing in any aortic infection, being dynamic, evolving, can become resistant to medication, doesn't make your life any easier. And the limited literature that we have has made the decision-making around how to manage them quite difficult and a freestyle, depending on the center experience and the surgeon experience. Now, the diagnostic dilemma has resolved. We all have been using these kind of clinical radiological laboratory diagnosis for very long. And now this is the MAGIC criteria that was published by our group. And it is actually endorsed and accepted by the European Society guidelines as the way to diagnose. Well, that's good. The mycotic doesn't have very strict diagnostic criteria. We don't diagnose a mycotic aneurysm most of the time, and we come to the management that are really very important and has not yet been answered. And I'm going to go chance of cure. Going on to this level of graft salvage technique, which means washout, drainage, or mental wrap, but you're going to leave the prosthetic in or part of it. Going into what we call now a palliative option, which is antimicrobial suppressive therapy for life, but do not expect life to be too long with those patients because they're going to get resistance to antibiotic and they are going to relapse. or leave them alone without antibiotics. So these are the options, and I think they are in the kind of order of what would or could achieve cure to patients. And that is actually our first part of the algorithm was built. But remember, there will be parts in the top here, but this is the part down here. So graft infection, when they present to us, are they bleeding or not? Because they might be bleeding from a fistula. If they are bleeding, we temporize them with a stent to stop the bleeding. We separate the bleeding from the infection. And then they become a graft infection that is not bleeding and septic only. If they are fit, they go for complete explantation, anatomical, biological reconstruction. If they are not fit, we choose from option 2 and option 3 that we talked about before, which is a graft salvage technique or antimicrobial suppression for life. We really try to shy away. We offer complete explantation. So because we know that the option 2 and option 3 are really inferior compared to complete explantation. And you can see here that we've developed also the follow-up protocol in detail, 6 months, 3 months, and we've done up to 5 years quite vigorously. They have of IV and 6 weeks of oral antibiotic, and then we stop. We follow them with PET scan, with CT scan, and they have specialized MDT and specialized clinic. Now, I'm not going to go through that because there is a lot of technical parts here, but we have reconstructed, used all sorts of biological grafts, deep vein. We use fascia lata instead of the Teflon, bifurcated grafts. We used bovine, we use composite, any biological grafts that you need, depending on the anatomical requirement, but try to achieve complete explantation, biological reconstruction, and very good biopsies. And again, depending on the extent, you can have different types of reconstruction. Now, aortic graft turned out to be a huge range of microbiology. You have multimicrobial or monomicrobial, but they're usually polymicrobial, and organisms is quite vast. So actually, this is the bit that is not evidence-based. How long to give antibiotics? Very poor literature. The 6 and 6 that we use is something that antibiotics. The short answer to that is the treatment is control the sepsis and seal the hole.
Please, 2 minutes, please.
So the idea is to sepsis eradication, because this is what caused the hole in the aorta, the mycotic aneurysm, and plus of course, some sort of reconstruction to the aorta, and this is what achieved cure. Open surgical repair or endovascular repair, plus or minus some drainage, have always been debated for very long. This is a famous meta-analysis which looked at the outcomes. And you can see here that the outcomes are not vastly different. Again, endovascular a little bit better in the beginning, but it loses some of that as it goes on. So they are comparable, and they are remain to be fatal. Now, all of the comparison that we've seen seems to be anatomical in most of the literature, and is this the right direction? I don't think so. I think the microorganism makes all the difference. The problem is we cannot select the patient who will respond very well to antibiotic and stent only early. That's the problem. The problem is if you stent them all, some of them will do well with antibiotic, some of them will relapse. And we cannot find out this easily before we start. So the milestone publication by the European group has shown, it is one of the ones that really changed our practice, that some of them are going to do well, but some of them are going to relapse, but we cannot predict this. The salmonella sensitive ones seem to do really well with antibiotics and endovascular. Most of the other relapsed at some point and actually didn't do well if you follow them up. If you send them away, you wouldn't see them and you would say endovascular and antibiotic worked. And this is our current algorithm for the mycotics. And you can see here that what we do is if they have a good endo option, we do endo first, pretty much for everyone. And a good, I mean a good technically without big compromise. And when they go for an endo first, they either have good response to antibiotic, we carry on for 1 year antibiotics, and that's the left side of the protocol. And then we stop because we don't want patients to take the side effects of lifelong antibiotics. If they do well after we stop, then they are cured, and they are the good group that responded to antimicrobial and stent. If they don't do well, then they of graft infection. They're not mycotic stented anymore. If they relapse, it means there is still infection and it's got to the fabric, or at least that's the assumption. If they poorly respond from the beginning, it means that the infection is too overwhelming for the antibiotic and it will get to the graft. They go to the graft infection side. From the beginning, if the bad endo option, then they are either fit, they have a primary open, or unfit, and they would have palliation or the bad endo option. And here are the different types of the microorganisms. They cause the biofilm, and skip those ones. These are some examples only of navigating the protocol, just to get you to the last slide, which is basically trying to get all of this algorithm together. This is one, and that's it. So if you see here, this is actually the protocol merging mycotic aneurysm to graft infection, using an endovascular first, using an endovascular first protocol to achieve selection of those who are going to be cured with endovascular. Some of them will fail, we know that. We stop the antibiotic to let them who are going to fail and declare themselves as a graft infection. Once they become a graft infection, if they're fit, they get explanted. If they're not fit, back to antibiotics for life, but we know that the prognosis is good. I'm actually very proud, as you can, passionate about this algorithm. I think it will evolve more. It's a bit expensive way of predicting who's going to respond to antibiotics. And I hope that in the future we will have more pathogen identification, targeted antimicrobial, hopefully more evidence and the antimicrobial choice and duration acting in the literature. More of the shelf options for endovascular, so that no anatomical checking my visceral segment. And
And of course, we can identify patients who are about to rupture their aortic aneurysms. We could try and treat them early and save millions of lives. So our objective has been to develop and test molecular image probes. I'm going to take you through that process that we do at St. Thomas's. Firstly, we identify a target. We then develop and look at this target. We translate that into systems through osmotic pump infusions of angiotensin II and a surgical model of deep vein thrombosis in which we create stenosis in the IVC. So what's new? Well, over the last decade or so, there's been an increased understanding of the inflammatory processes that really underpin atherosclerosis. We know when plaque ruptures, there's thrombus that forms. We know angiogenesis is imperative to this. Endothelial permeability and dysfunction is perhaps if you look at the top here, this is a histological section that has been taken. This is elastin, this is collagen, and this is atherosclerosis, aneurysm inflammation, as well as in cardiac disease. And if it's high, it makes it an attractive target for MRI detection. So what do we do to go and try and do this? Well, first of all, we need to identify what peptide we're going to be doing. So there are multiple candidate peptides that we go through genetic libraries. We look at leading candidates before we start to synthesize and label these peptides with gadolinium tracers and make sure that tracer is both stable and it works in an MRI machine. And this whole process is an iterative process, lots and lots of failure. Unfortunately, it does cost a lot of money and takes a lot of time. But we have found at least 4 different imaging probes that we're now through to testing, some in a bit more advanced processor than others. Elastin, tropoelastin, and more recently we've been awarded a large research, medical research council grant to look at both collagen 1 and collagen 3 in the experimental setting. We then inject these probes into murine models. We use a clinical MRI scanner, but inside that scanner we put a little murine, a murine model here and a murine coil, which we can look at the information in more detail. So what have we done? Well, this is a paper that we published in Medicine about a decade ago in which we quantified the total amount of elastin in atherosclerotic lesions. And you can see as the amount of elastin goes up, so can you measure the amount of time. These can then become cross-linked elastin and cross-linked collagen. And this is under enzymatic degradation and processing that goes on. So we've taken that information and in a murine model, and this is the aortic arch of a mouse, and we scan the brachiocephalic artery, and over time you can see that there's an amount of plaques over 12 weeks. And looking at that, we can actually quantify the amount of tropoelastin to plaques that don't. So using our tropoelastin model, we're able to differentiate which of those high-risk plaques are present. And indeed, even human patients that we've extracted the carotids from, we can differentiate high-risk plaques from those that are not. So what is now visible in 2023? Well, taking together everything that we know, and a lot of this work that we've been doing has taken up to 15 years to do. We can look at the endothelium, we can look at permeability through the endothelium itself. We can look at the accumulation of mononuclear phagocytes, macrophages that are pivotal to the inflammatory process in atherosclerosis. We can target lipids directly. Importantly, and more recently, some exciting work that we've just put to circulation is looking at myeloperoxidase, which is a marker of neutrophils, but also pro-inflammation and redox reactions, apoptosis, neovascularization, and as I rightly said just now, the extracellular matrix in terms of both elastin and collagen. So in summary, today, I think we need to think about the shift from anatomical imaging to biological imaging of disease. We don't need to have all of that information because we're getting a lot of information from the anatomy, but by taking a hotspot approach, we can concentrate to understand the presence or absence of this contrast uptake to give us an idea of exactly what might be going on in any particular patient. Signal quantification can be used to stage a disease more accurately and also to monitor therapy in response to these things. There are, of course, less stringent requirements of spatial resolution monitoring correction, but right now, we believe that it is possible to make the invisible visible. Thank you very much.
So this is another talk about one of the fairly recent innovations in terms of the application in vascular surgery, not as valuable and advanced as what Mr. Saha just presented, but interesting one to share. So St. Thomas has its pediatric hospital that's called Evelina London. We are lucky and unlucky to have that, but we do see some pediatric patients every now and then. And we all know in vascular surgery where pediatric patients are rare and they are usually challenging, apart from the trauma ones and the ones that we see in intensive care every now and then because of iatrogenic lines or sepsis-related ischemia. The elective ones can be 1 or 2 a year in big centers. You see that they have difficult, usually late diagnosis. They have multiple comorbidities. They are technically demanding. Younger the baby, the more comorbidities, the more difficult the plan would be. The lack of evidence, again, another topic with lack of evidence and less open surgical expertise and not necessarily endovascular brilliant options for a 1 millimeter and a 0.5 millimeter blood vessel. So I'm going to talk about 3D printing today, not about pediatric vascular. And this guy is pretty much one of the founders of 3D printing, Charles Hull. He's been awarded a very prestigious award 2 years ago or 3 years ago. Started off the 3D printing in 1984. And since then, you can see applications mainly gone through mechanical, gone to orthopedic, replacement of skull, and sometimes extended more. Many studies since then across the medical field, most of them in the last 10, 15 years. And they are all mainly cardiac, maxillofacial, orthopedic. These are the ones who started 3D printing. And the 3D printing is, this is because I was very interested when I saw it actually happening. You do a good 3D reconstruction, segmentation of the images you want to print, and then you go to the printer, and this is actually a printer in action below. You put the block of silicon, after you put the segmented CT images, when you separate all of the other stuff and you only print what you want, and the printer keeps going back and forth. Expensive, time consuming for now. And you can make anything you would like in a 3D print, very simple mechanical shapes that they use in industry into full organs simulated by the silicon. So we are lucky we have one of those on campus just because of the research facility, but it is still very inaccessible technology to find in healthcare organizations, and we will see what can we do in terms of the application. Started off by the renal transplantation team, and Pankaj Chandler, who's our pediatric transplant fellows, has done a lot of research on that, and many of these of him and many of the patients. So they started looking at 3D printing and its value for pediatric transplant, and they've looked at 2 groups that are very challenging. Size discrepancy, when a kidney from an adult is put in a pediatric, and whether 3D printing will help in the counseling, in the planning, and in getting better outcomes for those patients. And the second thing is abnormal vascular of a child when they have a previous jump graft or angiomatous malformation. Would the 3D printing help the operative team to plan their pediatric transplant a bit better? Done a lot of work on that, and they have published quite a reasonable amount. I was not involved in this. I knew about it, and it was working really well at the time. You see here, they get the IVC aorta with a bifurcation, then they get the adult kidney printed as well. Then they try to fit the adult kidney into the pelvis of the pediatric, see how it would fit on the arteries, what length would they need for the blood vessels, because you can't squeeze the kidney down in the pelvis to make the artery and the vein very close. And they've done models like this where they have tested and talked about preoperatively. They did publish their work. I was involved a little bit on that time, and they did publish the value of 3D in challenging very small kids transplantation. We were inspired by that, and we had a renal artery aneurysm, very rare one, Hyler, quite complex. The threshold to treat was a bit difficult, but then we decided we are going to treat it with an open repair and a full reconstruction. And you can see here the complexity of the Hyler aneurysm, quite complex with multiple branches. I think this is a video, this should work. And what we've done is we decided we will 3D print that and again use it for planning and for counseling. Planning the conduit, we will need a trifurcated graft from between vein and long saphenous, but also we will need a bit more than that to counsel the family and debrief with the team. Ended up with this model. and ended up doing this final debrief just before the operation, gone through all of the plan. Where are we going to clamp? How are we going to reconstruct? And we used it for our planning of the conduit. This is a bit of internal iliac and a bit of long saphenous joined together. And the 3 pictures here showing how we reconstructed at the end. The value here of 3D printing was the family counseling, the surgical planning, and the debriefing with the theater team at the time for a case that we don't do every day. In fact, we did 1 in 5 years. Then the mid-aortic syndrome was another example where there are, as you know, multiple types of them, but they're not as simple as this classification. They come with all sorts of different segments of aorta. And again, we had this 3-year-old preserved to thrive for 18 months, hypertensive crisis, mid-aortic syndrome. You can see a long list of morbidities, GSTT, and on thoracoabdominal aorta, someone who's 3 years before, special segment and renal at that time. And then we decided that we are going to get her aortic segment that goes from 8 to 2 millimeters in the viscous segment, then back to 6 infrarenal and single kidney. So we decided to 3D print it. Again, the focus here is about the 3D printing. And we did that. We prepared all of her 3D printing. We decided how we're going to approach through a thoracolaporotomy, visceral rotation. We've done I even tested some of the cannulas for perfusion. I have to say it did calm me down a bit. I'm not saying it's essential, but it is valuable. And we ended up with